Smoke inhalation is a complicated and serious illness from which many people die, but oftentimes it's dismissed as just smoke inhalation. We have to change our attitude and look at the issue with new eyes. And if we can do that, we can start saving lives.
Sometimes we make decisions that are based on what I think is old medicine.
It really makes you wonder if we may be changing the landscape, not only for cyanide exposure, but also for carbon monoxide exposure.
I think it's incumbent upon every American firefighter to understand the toxicity of smoke, and not only to understand it for their own safety, but for their family's safety, for the people we swore to protect.
Hi, I'm Rob Schnepp. Smoke is everywhere, and the fire service knows it. You know it. It's also well known that smoke kills more people than flames. Often, carbon monoxide gets all the credit when we think about the dangers of smoke exposure. Rarely acknowledged is hydrogen cyanide, which is created during the combustion process of burning laminates, synthetics, foams, plastics, and even wood. Nearly everything in our homes and offices today. And when smoke inhalation victims are exposed to both toxicants, their medical conditions become much more complicated. In short, hydrogen cyanide and carbon monoxide are deadly together. This is why we call them the toxic twins. Up until now, the vast majority of firefighters would equate the worst cases or releases of carbon monoxide and hydrogen cyanide with hazmat incidents, or chemical warfare, or an industrial accident, or some other sort of dangerous situation. And you know that if dispatched to any one of these incidents where carbon monoxide or hydrogen cyanide was identified or suspected, your approach would change. Your tactics would change. And most importantly, your perception of the hazard would change. And that's the key. As you sit there today watching this video, be prepared to change your perception of fire smoke. The reality is that hydrogen cyanide is present on some level on the scene of every fire we run. This includes structural fires, vehicle fires, dumpster fires, and while you might not think so, wildland fires, especially the wildland-urban interface when homes and buildings are burning. When a firefighter or civilian breathes smoke and requires medical attention, they become a smoke inhalation patient. Between 1997 and 2006, over 182,000 people in the United States were diagnosed with smoke inhalation, and more than 30,000 of those people died from that illness.
We've spent probably 20 years of collecting data, and looking back at that time, we've had virtually no civilians come out of a structure fire or a smoke exposure in cardiac arrest who we've been able to resuscitate. And in fact, I think most EMS providers around the country probably have a similar experience. The ability to bring back somebody who's gone into cardiac arrest from smoke or from exposure in a fire is virtually nil.
So you might be asking yourself, what is smoke inhalation? Well, a basic definition is the breathing in of harmful gases, vapors, and particulate matter contained in smoke. I know it's a somewhat nebulous definition, but suffice it to say that smoke inhalation is definitely an illness.
We look at the number of people that are smoke inhalation victims a year that die, how many of those would really have died, and how many of them would have been viable if we used an antidote like hydroxycobalamin on the patients. Maybe we would consider a lot more people viable than we do now.
So this program will teach you to better understand and treat that illness. Here's a few important things you'll learn. First of all, you'll be aware of the destructive physiological processes of hydrogen cyanide and carbon monoxide, and really importantly, that hydrogen cyanide is present on every fire ground at some level. You'll also learn how to assess smoke inhalation at the basic life support level, or BLS, and the advanced life support level, or ALS. And lastly, you'll learn how to administer aid to the smoke inhalation victim and treat that exposure. So, before any of this will make sense, as a first responder, you have to accept the fact that hydrogen cyanide could be present at any fire, and must be considered when treating a smoke inhalation patient. There are numerous toxicants within fire smoke, but there are two that challenge the pre-hospital care provider when it comes to assessment and could potentially complicate any treatment rendered. Remember this: hydrogen cyanide and carbon monoxide are the toxic twins. So let's take a moment to understand the physiological process of hydrogen cyanide and carbon monoxide. Normally, oxygen is transported from our lungs to the rest of the body within red blood cells inside structures called hemoglobin. These act like little seats on a bus, carrying passengers to a particular destination. The oxygen molecules leave the red blood cells and are delivered to the body cells, which then use oxygen to generate energy. This allows, among many other body functions, a normally beating heart and an intact neurological system. Simply stated, carbon monoxide replaces much of the oxygen being carried by the red blood cells by taking up most of the seats, which reduces the amount of oxygen reaching the cells throughout the body. Less oxygen delivered to the cells means less energy production and impaired organ functions, including challenges to our cardiovascular and neurological system. Carbon monoxide's toxic twin, hydrogen cyanide, acts within the cells to disable the cell's ability to use what little oxygen is reaching them. This may result in a buildup of lactic acid. Hydrogen cyanide is a principal cause of incapacity or death because it is driven directly to the heart and brain. These organs in particular rely on a substantial supply of oxygen and therefore experience the most immediate insult. If you breathe smoke containing hydrogen cyanide and carbon monoxide, this is what's happening in your body. So keep in mind that large exposures can result in severe symptoms within minutes and even death. And even if you have never gone down from a smoke exposure, you've certainly been exposed to sublethal levels. And who knows now what your heart or brain looks like. Hydrogen cyanide kills the organs and carbon monoxide is the thing that kills the blood. Both these things, in conjunction with each other, create a challenging situation for any pre-hospital care provider. Now that you've seen the destructive capabilities of hydrogen cyanide and carbon monoxide within the body, it's important for you to accept that these toxicants are on the scene at your fire ground. And while this program is not about detecting hydrogen cyanide in fire smoke, we thought it might be wise to show you that the threat of hydrogen cyanide exists in virtually every fire you go to.
And so they'll call me up and say, oh, we got another kit we want to try. We need some cyanide poisoned people. And so usually I just call one of the union halls and say, you know, you guys have a fire in the last day? And they're like, yeah. I said, all right, I need 5 guys who are at the fire. Just bring them down, test them. They always have cyanide in their blood, you know. Any firefighter's been in a fire, they always have some.
Hydrogen cyanide is generated during the combustion of all kinds of household and workplace items. Items like sofas, cabinets, desks, drapes, blankets, and carpets. Hydrogen cyanide is not immediately identifiable by the smoke. Not by its color or its amount. Hydrogen cyanide is invisible and only detected through metering and monitoring. Here are some important values to think about. The immediately dangerous life and health value, IDLH, for hydrogen cyanide is 50 parts per million. As you can see, NIOSH's recommended exposure limit is 4.7 parts per million. OSHA's permissible exposure limit is 10 parts per million. And the Environmental Protection Agency's acute exposure guideline level, where life-threatening effects or death will occur, are 27 parts per million for 10 minutes or 21 parts per million for 30 minutes. Let me share with you a few real-world examples. Here's a pan on the stove, moderate smoke, 22 parts per million of hydrogen cyanide. A dumpster fire, 25 parts per million of hydrogen cyanide. This is a bigger example, a warehouse fire. 26 parts per million detected around the exterior, not in the active fire, but at the exterior of the building. Think about where your command post might be placed in a scene like this. Small fire in an apartment complex. Had nothing more than smoldering cabinets, pot on the stove, very little fire damage, generated 30 parts per million. This slide shows a reading from a training exercise, 48 parts per million of cyanide. What's interesting about this is the reading was taken at the backside of a burn building with only hay used as a fuel for the training fires. These meter readings that you see are taken by firefighters, your colleagues. They're not doctors, they're not scientists, they're not researchers doing work during controlled fires in a laboratory setting. Are you surprised? You shouldn't be. Hydrogen cyanide is your new invisible enemy. Accept that. When we put on our hat of pre-hospital care provider, we need to be conscious that the inhalation victim is exposed to the incipient stage of the fire. This is the combustion process when hydrogen cyanide is the most prevalent.
People have asked recently about the Underwriters Lab study, the smoke characterization study, which essentially told us that cyanide was not found in the active fire phase of fires, and raising a question of, if we're not finding it in the fire itself, how is it getting into a patient, and is it really in the patient? What Underwriters Labs was doing in that study was measuring the characteristics of smoke from live fire, and there certainly is a whole lot of period before and after a fire that was not included in that study. In the pyrolysis stage, in the incipient stage of a fire, when things are starting to burn before you see flame, they off-gas tremendous amounts of all kinds of things, cyanide being one of the major things that is present. And in situations where there's been a high quantity of those sort of combustibles, we found tremendous amounts of cyanide in the victims at the fire. So the Rhode Island nightclub fire had huge quantities of cyanide in the victims of that fire, because there were components in the smoke during the initial incipient or the pyrolysis stage of that fire that poisoned those people.
While firefighters are wearing PPE, specifically an SCBA, now that's providing you're wearing it and using it, the civilians aren't. They are exposed to the highest levels of hydrogen cyanide from the very moment the combustion process begins. And wildland firefighters are not exempt from hydrogen cyanide exposure, most especially in the wildland-urban interface environment when homes and buildings are burning. And quite frankly, the wildland community could be at a greater risk because they typically don't wear SCBA. And even though structural firefighters have the benefits of SCBA, not using that air, by choice or by circumstance, like an out-of-air situation, puts you at risk. This also includes incident commanders, or those firefighters operating outside the building, who might even be out of the range of visible smoke, but certainly could be exposed to near IDLH levels of hydrogen cyanide and not even know it. This is what we've learned so far. Hydrogen cyanide kills the organs by disabling the cell's ability to use oxygen in the generation of energy. Carbon monoxide kills the blood by disabling its ability to transport oxygen to the organs. And I think we've shown, beyond a doubt, that these two toxicants are on the scene of every fire you run. Now you see the problem. But it's important to realize that out of all the dangerous components in smoke, hydrogen cyanide is a toxicant whose health effects can be reversed by an antidote. An ideal antidote is not harmful to patients with concurrent carbon monoxide poisoning and will be quick, safe, and easy to administer. Currently, there are two antidotes available for hydrogen cyanide poisoning. One, called hydroxycobalamin, is currently marketed in the United States as Cyanokit. The cyanide antidote kit, which we will call from this point CAK, is also known as the Lilly Kit, Pasadena Kit, and the Keystone Kit. But for the most up-to-date information on how and by what name these drugs are being marketed, please visit firesmoke.org. Using the CAK in its entirety is actually contraindicated in the face of smoke inhalation because it contains nitrites, which decrease the oxygen carrying capacity of the red blood cells. That means it fails as an ideal antidote for smoke inhalation patients because victims of carbon monoxide poisoning already have a decreased oxygen carrying capacity. Keep in mind, the CAK also contains sodium thiosulfate, which can in fact be administered to smoke inhalation patients. But don't worry, in an attempt to clarify what these drugs do once administered, we will take you back inside the body to explain how the drugs interact with the toxic twins. This information is very important, and before we go any further in the program, I need to drive this point home. It's in your best interest, and in the best interest of the patients you are treating, to educate your local medical community in order to prevent the administration of the entire CAK to smoke inhalation victims on the scene or at the hospital. So based on that, let's first see what happens when the entire CAK is used. As we discussed earlier, during normal body function, red blood cells transport oxygen from the lungs to the rest of the body within the little seats called hemoglobin. When certain drugs of the CAK are administered, most notably the sodium nitrite and the amyl nitrites, they promote the formation of a different kind of seat within the red blood cell. This seat absorbs hydrogen cyanide instead of oxygen. And when the red blood cells absorb hydrogen cyanide instead of oxygen, there is less hydrogen cyanide reaching and attacking the body cells and interrupting energy production. Also, these new seats within the red blood cells act like magnets to the hydrogen cyanide within the cells, removing the hydrogen cyanide and allowing energy production to resume as long as the cells are receiving oxygen. But the problem is, at its most basic level, the cells are not receiving oxygen because now that the red blood cells are transporting hydrogen cyanide, there are way fewer seats for oxygen to make the journey from the lungs to the rest of the body cells and create energy. Also, in the presence of carbon monoxide, which, as we learned earlier, also takes up seats within the red blood cells, way before oxygen can, there is even far less oxygen being delivered to the body cells. So think of it this way. Even though we're pulling hydrogen cyanide out of the cells, which you would think would be the right thing because it allows energy production to resume, not enough oxygen reaches the cells to fuel this process. And really it all boils down to this. Oxygen needs to do its job. Another thing to keep in mind is that sodium nitrite and amyl nitrite are vasodilators, which lowers the blood pressure. And this is bad because victims of hydrogen cyanide poisoning already have low blood pressure, making sodium nitrite a dangerous drug in the setting of smoke inhalation. Sodium thiosulfate is the third component of the CAK and is the only drug safe to give to smoke inhalation victims. Within liver cells, sodium thiosulfate combines with hydrogen cyanide to form thiocyanate, a far less toxic version of hydrogen cyanide that can be excreted in the urine.
Well, the kit that we used before for cyanide exposure is really designed for when you're exposed to cyanide. And if that's all you're exposed to, then all the things that are in there are beneficial. But when you've got a mixed gas exposure mixed with carbon monoxide, and you use all the components in there, well, you know that the carbon monoxide binds the hemoglobin. And it has 200 times greater affinity for the hemoglobin, and so the oxygen can't get on it. Well, some of the components of the other kit will also bind to hemoglobin, and you develop a condition called methemoglobinemia. And in the end, what you've done is you've taken even more hemoglobin, you've neutralized more hemoglobin, and so there's even less oxygen carrying capacity in the blood. Really, the only component that is helpful is the sodium thiosulfate. The other ones will actually make the situation worse. And the sodium thiosulfate by itself is helpful, but I don't think it's as good as what we can get with the hydroxycobalamin. And so between the two, that's why the Houston Fire Department, we went to the hydroxycobalamin.
In the face of severe smoke inhalation, hydroxycobalamin is the antidote to consider as treatment in hydrogen cyanide poisoning, as it can be safely given to a smoke inhalation victim with concurrent carbon monoxide exposure. Simply stated, hydroxycobalamin binds to hydrogen cyanide to form vitamin B12, which is harmlessly excreted in the urine. The good news is, hydroxycobalamin has a very simple mechanism of action. With less hydrogen cyanide in the body, cells are able to process oxygen and create the energy it needs to keep the organs working. Remember, this is all about letting oxygen do its job. Sounds simple, doesn't it? Actually, it is. Hydroxycobalamin has no known adverse effects on the oxygen-carrying capacity of the red blood cells and does not decrease blood pressure. Both of these are potentially significant benefits when treating victims of smoke inhalation. Hydroxycobalamin may interfere with the accuracy of some laboratory values, and depending on local protocol, blood may be drawn for cardiac enzymes, serum lactate, and basic chemistries prior to the administration of the medication. However, blood collection should not delay medication administration in any circumstance. Because of the color of the drug, it results in a red discoloration of the skin of the patient and red-colored urine for up to a week. There are no contraindications for administering hydroxycobalamin in the field. This is a very important point. Once again, let's review. Hydrogen cyanide kills the organs, carbon monoxide kills the blood. These toxicants are on the scene of everyday fires, and now you know that hydroxycobalamin is a safe drug for smoke inhalation victims in the face of hydrogen cyanide and carbon monoxide exposure. We can now discuss how you can assess smoke inhalation victims to determine if antidotal therapy is indicated. As toxic twins, hydrogen cyanide and carbon monoxide share similar effects, and it can be hard to differentiate between the two. Identification of carbon monoxide poisoning can be achieved with a carbon monoxide oximeter, if it's available. But there is no definitive field test for hydrogen cyanide poisoning, and this is a problem. However, there are signs and symptoms that first responders should look for in the limited window of the pre-hospital environment to determine if drug treatment is necessary.
If we were to wait until we got a cyanide test back, we'd be waiting several days, if not 7 to 10 days in actuality. And I think that's the experience in most places in the United States. There are a very limited number of labs that are actually on the list of laboratories that the CDC says are okay to run cyanide tests. And so for us to get that actual lab value back would be long after we sent the blood to the laboratory. So the presumptive diagnosis, and it has to be presumptive, is based on signs and symptoms in the patient.
Once a smoke inhalation victim has been rescued, he or she must quickly be removed to a safe area away from the smoke intoxicants for further assessment and treatment. If you can answer yes to all three of the following questions, treatment for hydrogen cyanide exposure should be initiated in the pre-hospital environment. First of all, was the victim removed from a closed space structure fire? Second, is soot present around the nose and mouth? And last, does the patient present with an altered level of consciousness or some other abnormality in their mental status, such as giddiness or the inability to answer questions appropriately? These three indicators are present, there's a significant chance that the victim is suffering from acute hydrogen cyanide poisoning, and pre-hospital treatment should be administered immediately.
Here in the Houston Fire Department, if we pull someone out of a fire, whether it be a civilian or a firefighter, doesn't matter, and they have been in a confined space and they've got smoke inhalation and they have altered mental status, that's really all we're looking for, is altered mental status, because at that point you have to make the assumption that the cyanide has gotten in and is interfering with oxygen delivery to the brain, and that's why they're altered. And if that's, so really that's the criteria, and we will then start the hydroxycobalamin therapy.
Other indicators include low blood pressure, called hypotension, shock, nausea, vomiting, convulsions, possibly a pinkish to cherry red complexion caused by the abnormal high oxygenation of venous blood, and in some instances, the victim's breath may have an almond-like odor attributed to the excretion of small amounts of hydrogen cyanide in the breath, although in the setting of a fire, this may be very difficult to detect.
Our thought process now is that when you have an individual who's exposed to smoke or products of combustion in some way, shape, or form, that individual should be thought to have cyanide poisoning if you can't explain by any other reason some hemodynamic disorders like hypotension, altered level of consciousness, seizures, acidosis that doesn't resolve from other kinds of treatment.
If a firefighter were to require treatment for whatever reason, the same indicators apply, and most especially in an out-of-air situation. If a firefighter is the smoke inhalation victim, ask yourself one additional question. Was the firefighter using, not just wearing, but using air at the time of the exposure? Cyanide is also much more difficult to recognize in firefighters unless the exposure is acute, because for the most part, they aren't honest with themselves if they don't feel right and don't want to let anybody know. Two primary indicators first responders can look for in their brother and sister firefighter are severe lethargy or giddiness. Again, this is difficult to recognize because firefighting is very strenuous. Acute exposures, it won't be hard to recognize the symptoms, which include low blood pressure, shock, nausea and vomiting, and convulsion. And if the victim, whether a civilian or firefighter or other public safety responder, is unconscious or in cardiac arrest, you've got a good candidate for antidotal therapy.
The following information is a general overview of smoke inhalation treatment and is not to be used as a specific medical algorithm for aid.
Before discussing the suggested BLS and ALS treatment protocols for smoke inhalation, we should probably talk about a few basics. Remember that smoke and products of combustion will cause poisoning and direct irritation of the airway and lungs. And any injury of this type to the airway or lungs will definitely cause an impaired ability to oxygenate and ventilate. Any pre-hospital treatment for smoke inhalation must include the administration of oxygen. Once the victim has been rescued from the environment and becomes a patient, always move that patient to a safe area far away from the smoke intoxicants for further medical assessment and treatment. Quick field decontamination is recommended. This includes removal of the patient's clothing and a quick wash with water if time permits. You can think of this in the same terms of how you would manage a basic trauma patient. You perform a quick strip and flip prior to transport to the hospital. What this does is it protects all of the caregivers down the line from secondary exposure to the off-gassing of the byproducts of combustion that might be trapped in or on the patient's clothing or skin.
Basic life support includes establishing an airway, ensuring the patient is breathing, ensuring the patient has blood circulation, and administering high-flow oxygen. Evaluate and treat any burns and/or trauma and consider spine immobilization if indicated. Remove the patient's clothing and, if appropriate, do field decontamination.
If the patient is responding positively to basic life support, antidotal therapy may not be required. However, rapid transport to the appropriate receiving hospital is indicated.
Advanced life support includes establishing IV or IO lines, treatment of underlying conditions including cardiac arrest, respiratory distress or arrest, and seizures. Assess the patient for hydrogen cyanide poisoning as discussed earlier, and treat with antidotal therapy if indicated. Transport the patient to the appropriate receiving hospital.
The suspicion of acute hydrogen cyanide poisoning should prompt the pre-hospital provider to consider antidotal therapy based on local protocol. Carbon monoxide and hydrogen cyanide toxicity associated with cardiac arrest, secondary to smoke inhalation, may be treated with hydroxycobalamin. Refer to the package insert or your local protocols for hydroxycobalamin dosing information.
So one of my philosophies is the key to this whole thing is to get the ball rolling in the pre-hospital setting. Clearly, the sooner we get started, the better. In a couple of the cases, we saw them develop neurologic symptoms, some recovery of neurologic function halfway through the first bottle. And as you know, for an adult, it comes in 2 bottles, and it's a 2-bottle administration. But halfway through the first bottle, they started moving. And so what that tells me is that it's very rapidly acting, at least in taking, getting to the point where the brain can start to function again. And man, I'll tell you what, if it's my firefighter or my family member, I want that happening as soon as possible. So we're going to get it started in the field. But the number one most important reason is that's patient care oriented. We've used a fairly large number of times here, more so, quite honestly, than I had anticipated. A fire where the second-in company went in to fight the fire. There was a flashover. When that occurred, a captain somehow got away from the pack. And as soon as they came out, they recognized he was missing. They immediately went back in. They found him in the room adjacent to where the flashover had occurred. No helmet, no face mask. They dragged him out. Again, it's difficult getting folks out when you can't see what's going on. They got him out. We got him on the heart monitor while we were doing CPR, and he was confirmed to be in asystole. No heart activity at all. Similar story, CPR, oxygen, intubation, epinephrine, gave the ACLS drugs, and added the hydroxycobalamin. Again, a very rough, rocky, prolonged road in the hospital. He has pretty significant burns to his face and to his hands, not surprisingly. But he is back to work, 100% neurologically intact. He's a father, he's a husband, he's a firefighter. Tragically, one early New Year's morning, there was a fire in a home with 3 little girls. Ages range from 6 to 12, I believe. One of the girls came out, was awake, coughing, had smoke inhalation, but was awake. The other two sisters came out, one with agonal respirations, the other one not breathing at all. Both got CPR. They both got the cyanocobalamin or hydroxycobalamin kit, and again, a very long course in the hospital with the burns, and they went through all kinds of complications, metabolic complications, but in the end, they're back at school as a family unit. All three little girls are together again.
At the end of the day, you need to know that smoke inhalation is a complicated illness. And clearly, not everyone exposed to fire smoke warrants aggressive treatment, and it's up to you, the first responder and fire professional, to make informed decisions in the field. Both the prompt recognition of acute hydrogen cyanide poisoning and the immediate initiation of care are necessary for effective treatment. You, the fire professional, are often the first line of defense and the first person to provide medical care for victims of smoke-associated hydrogen cyanide poisoning in the pre-hospital care setting. This is what you do. And by recognizing hydrogen cyanide poisoning and effectively initiating corrective measures according to protocol, the fire professionals can save lives. You can save lives. However, keep in mind, all that we've talked about, all the antidotes we've discussed, they're not miracle drugs. And success is based on giving the right drug to the right patient at the right time.
It's not 100%. We've had other cases where we've had folks where we pulled out of fires and altered mental status and still had a pulse, and we've given the hydroxycobalamin, and some of them we got pulses back on, and some we didn't. In one case, we had a lady we brought out and got her pulse going again, and she got the hydroxycobalamin, and it turned out that in the end she had many complicated medical problems, and the family decided to withdraw care. But the thing that's of note for her is that our local hyperbaric chamber and burn center, where we bring all of our burn and smoke inhalation victims, she is the woman who now holds the record for having the highest carbon monoxide level of anybody with a pulse. And so we wonder if that isn't the case because she got basically the cyanide antidote. So in the past, all folks who had had that much carbon monoxide from the smoke also had so much cyanide that they didn't survive to the hospital. And in this case, while we couldn't completely reverse all the effects of her carbon monoxide, we at least were able to neutralize the cyanide such that her tolerance for carbon monoxide was greater than what it would have been otherwise. And as I said, tragically, in the end, the family decided to withdraw care, and they know better than I do, so they made the right decision. But it really makes you wonder if we may be changing the landscape, not only for cyanide exposure, but also for carbon monoxide exposures.
Strange as it may seem, there is also a common misperception that as patients move through the continuum of care, meaning from the pre-hospital environment to the emergency department to the ICU, they will receive a higher level of care when it comes to treating smoke inhalation. Unfortunately, that's not necessarily the case. It could be up to you, the pre-hospital care provider, to act as the patient's advocate as they enter into the system.
The other logistic reality of it is that the hospitals sometimes are a little behind the curve from EMS with some things, and this appears to be the case here. So if we can get the antidote started in the field, when it gets to the hospital, we know that they may ask, what is this? And I'll tell you what, the other thing is when you reconstitute it and it starts going, it's a bright purple red color, and it really gets people's attention, like, are you giving blood in the field now? So, no, this is, and we explain to them what it is. Here in Houston, most of the hospitals that we, there's only a couple of hospitals that we would bring somebody that's critical to. Well, their staffs today, they're familiar with it, but they're familiar with it because we introduced them to it on actual cases. Even though we had told them ahead of time, their hospitals are big institutions, and it's sometimes hard to get the information to filter down to the doctor and the nurse that are going to be there at 3 a.m. on Saturday when you bring the case in. And so we get started in the field. It's the best thing to do for the patient. The other thing is that it ensures that the patient's going to get the therapy. If the hospital doesn't know what it is, we teach them right there. They've always got a doctor with a fire department who they can call. We'll explain to them over the phone if they want. But our paramedic supervisors are very well trained and very well versed, and they give the information to the hospital. We've never had a problem.
Let me offer you another perspective. Think about your fire department and what you were doing with rapid intervention 10 years ago. I venture to guess that most people watching this video were not doing anything with rapid intervention training at that time. Since then, we've paid a lot of attention, we've spent a lot of time, and we've spent a lot of money on rapid intervention training. But let me ask you this. Without a smoke inhalation treatment protocol, can you really complete the save? So here's a take-home message for you. Firefighters, you, will continue to be exposed, and civilians will continue to die until we implement appropriate medical treatment for smoke inhalation. Again, the drugs that we talk about, the antidotes we talk about, they're not miracle drugs. But keep in mind, it's the right drug for the right patient at the right time.
You know, when I think about this, and I think, why wouldn't a department go this way? And you know, here in Houston, maybe we've been the oddball case, but you know, in the first several months of having it, we saved 2 children and 2 firefighters. And these are people who were essentially dead when we pulled them out of these buildings, and they're alive today. And so we'll never go back. Yeah, and so I would really ask folks, you know, why aren't you doing this? We lose way too many firefighters every year. We lose way too many civilians to fire-related deaths. And some of those, there's not anything we're going to be able to do about it. They were just in the fire too long, and there's nothing that anybody can do. But some of those folks are in that area where if we get them out and we manage them properly, they'll get back to work like our 2 firefighters, and they'll go back to school with their sisters, like the 2 little children we have. These are real cases. It really happens. It has really worked. You need to really consider it.
I hope this program helps you to be a more informed firefighter and a safer firefighter, because safer firefighters make for safer communities.